Well, hello, everyone, and greetings from wherever you might be joining us. It's really exciting to do this part of the program today. I think this is probably the thing that most people look forward to. So this is our live question and answer hour. And today we have two esteemed clinicians who specialize in cutaneous lymphoma who are joining us this morning. We have Professor Maarten Vermeer, who is joining us from the Netherlands, and he is the head of the Department of Dermatology at Leiden University Medical Center. And Professor Vermeer is an active researcher, physician, all-around expert in cutaneous lymphomas. And joining us from Italy is Professor Peitro Quaglino. And Professor Quaglino is the Associate Professor of Dermatology at the Department of Medical Sciences at the University of Turin in Torino. So welcome to you both. It's really an honor and a pleasure to have you joining us today and being available to answer questions from our audience, which is just so exciting. We're crossing all the ponds here.
Thanks to you, dear Susan, and to all the people connected. It's a great pleasure for me to be here with you.
Great. Go ahead, Maarten. Just want to make sure everybody's audio and everything is working okay.
Yeah, I've just been unmuted, I see in my screen. So
great.
Also welcome from me, and I'm very happy to be on this call.
Great. Well, thank you again both. And I know you both are fresh off of the European Academy of Dermatology and Venerology, the professional meeting that was being held, I think it was in Spain. So you both have just traveled back home and are here joining us today. So thanks really so much. And I'll remind all of our folks watching that you can put your questions into the Q&A box and you can write it in your language, and it will, through the magic of technology, translate on my screen in English so I can read it. And so we're going to go ahead and get started so we can use the most of our time together. And I'll kick off with a couple of questions. And again, as the questions come in, we'll take a look. But so, we've gotten a lot with COVID and all of the challenges that everyone has faced over the last 2 years. From either of your opinions, can you share about the immunocompromised cutaneous lymphoma patient? How, based on maybe someone's diagnosis, what's their immune system's resilience, I guess, and how maybe should they think about dealing with COVID and so forth? I know we've gotten a lot of questions over the last couple of years, and I know the clinicians globally have also been collecting data. So I'll toss it over to Professor Quaglino. You're shaking your head, so I'm going to let you go first if you want to jump in and just share your thoughts.
Yeah, thank you. And indeed, you had really 2-3 years with this pandemic, COVID pandemic, which broke out and is not finished yet, unfortunately, even if completely changed it, as I think it's what all of you knows and have experienced, that the feature, the characteristic and disease related to COVID changed a lot, and now basically less relevant lung infection, even if can be also severe. I think as a general consideration, I think at the beginning of the COVID pandemic, we were all worried about the fact that people, particularly other people, would be safe to get to the hospital, and then a lot of initiatives and help and work was given to improve the fact that telemedicine, the possibility to collect data from patients outside the hospital, and also to increase the safety for patients coming to the hospital with separate positions, separate area for waiting, and etc. Now the situation is better, but I think that we learned a lot from this experience. And first of all, generally, in my experience and also collecting data, as you mentioned, there's no particular risk for the fact of worsening of cutaneous lymphoma disease in presence of COVID infection, and no major risk in presence of cutaneous lymphoma for having COVID infection. For sure, immune-compromised patients treated by chemo, and as you know, the percentages of patients treated by chemo with cutaneous lymphoma decreased in the last years due to the fact that we have new active drugs that improve a lot our treatment options in these cases. Anyway, for sure, immune-compromised patients need to pay more attention in this to prevent COVID infection. But as a whole, I would say that there is a general there's a general agreement on the fact that there's no particular problems about the relation with COVID and cutaneous lymphoma. So no risk in both ways. So cutaneous lymphoma patients don't have a high risk for having severe COVID infection, and in the presence of COVID infection, there's no major risk of worsening in cutaneous lymphomas. For sure, for each case, I think it's important each patient refer to the specialized center where he or she are followed to have more detailed and more focused information for the specific patient situation.
Great. Professor Vermeer, any additional comments, thoughts?
I agree with Pietro. I think the one of the things we've learned during the COVID endemic or pandemic was how to reorganize our outpatient clinic. We tried to organize in such a way that we would see only patients in the hospital that we really needed to see, and we've tried to be very critical in making these appointments with patients. Then the other thing, so that was from a practical standpoint, how to organize our clinical care. And the other point is, are patients with cutaneous lymphoma more vulnerable to COVID? I don't think it's the cutaneous lymphoma itself, and we should always remember, of course, we're talking about a very heterogeneous disease or very different types of cutaneous lymphoma, and patients that have just one relative small patch or plaque mycosis fungoides is a very different patient from someone that has a very advanced stage of disease. So we have to take into account the extent of the disease and the type of treatment that patients are receiving, and both can compromise the immune system. And I think it's a good advice, and in particular for those patients with advanced disease, to be very careful in their contact with other people, so to minimize the risk for acquiring COVID. And second, I think it's important to realize that those patients that are will receive a chemotherapy or will have more intensive systemic therapies, it's a very good idea, in particular for them, but also for other patients, to go through the vaccination protocols. We have not seen adverse effects from vaccinations more in cutaneous lymphoma patients, so there's no reason to not take this vaccination program. And I would argue that because the disease and the type of therapies that we use can compromise the immune system, there's a very good reason to try to get as much protection as you can.
Great, that's great. Thank you both for that. I know that's top of mind for a lot of people, especially as, you know, COVID is waning a little bit perhaps, but still for many of us who are grappling with cutaneous lymphoma, trying to manage that and make the right decisions and get back to life, right? So that's very much appreciated. I'm going to switch to another question here, which talks about, asks about UVB light. We use UVB light a lot for treating cutaneous lymphomas and especially for early stage disease. And how long can you do UVB light? You know, given this is a long-term chronic disease, can we do it forever, or are there side effects? And I know there's a difference, and maybe you could talk about the difference between UVB light and UVA light, where we use PUVA, and maybe there's some differences there in the longer term effects of using either of the light therapies that we use in cutaneous lymphomas.
Yeah.
Professor Vermeer, you want to jump in?
Sure, that's an excellent question, and it's a question that that we also receive not only from patients but also from clinicians that we work together with. And I'll start with telling you a little bit about the types of UV treatment that we use. And it's important for this story to realize that UVB therapy, the penetration of light into skin is relatively low. So it will be, it can be an effective therapy for thin patches, or maybe patches that are on the brink of becoming a plaque, but it will typically, the light will penetrate just a little bit below the basal membrane. So not just in a superficial layer of the skin. And if your malignant cells are in that layer, then UVB can be an effective therapy. If lesions get a little bit thicker and tend to be more infiltrated plaques, or in particular in those patients that have a folliculotropic mycosis fungoides, where the tumor cell infiltrates are located a little bit deeper in the dermis around the hair follicles, then you would need a light therapy that can penetrate deeper into the skin. And then PUVA therapy, so psoralen combined with UVA, is preferred because that treatment penetrates deeper into skin. So that's the first answer, I think. Then the second is, how long can you use this treatment? And that's a difficult one, and I think should always be titrated and be tailor-made for individual patients. We get this question often from dermatologists that are accustomed to giving light therapy for eczema or psoriasis, and they have the regimen that they will treat, at least in the Netherlands, for up to 3 months, and then they will stop. For cutaneous lymphoma, is a completely different disease, and if a patient is profiting from the treatment, we tend to use it longer, maybe 4 months or even 5 months, or even a little bit longer. But of course, at a certain point, you want to stop it, because you do not want to have someone in light therapy indefinitely, for practical reasons and also because of cumulative toxicity. You can, if use it in a clever way, in such a way, you say, well, let's use it in the winter months, and then in the summer months we will stop treatment, and patients can profit from the natural sunlight, and then it will make also life a little bit easier for patients, because it's very difficult and limiting, of course, to always have to go to the clinic or a clinic twice a week. The specific cumulative toxicity that we are worried about would be the induction of other keratinocyte-based carcinomas, so new skin cancers, but then skin cancer that would develop from keratinocytes. And we have seen this indeed in patients that have had a very, very extensive use of light therapy. So it's always a balancing of different things. One is how effective is this therapy? Is it really working for a patient? Is it a treatment that patients can easily incorporate into their daily activities? Is it how much light therapy did someone already receive, and what's the age of the patient? So combining this all, then you, together with the patient, you decide on a specific strategy. And typically you try to rotate your different therapies that you have. And I would say, as a general sort of rule of thumb, I think more than 3 months, yes, because we are dealing with a different disease than eczema or psoriasis. And I think if you have patients already for half a year, you would have to have this discussion. Is this still working for you? Is this still something that we think will give you additional benefit by continuing it, or should we try to find an alternative?
Great, thank you. Professor Quaglino, anything to add on light therapy?
Yeah, basically, yeah, yes. I completely agree. There's no doubt with what my colleague and friend Maarten told and explained to all the people. And if I can make a couple of rapid consideration, a little bit also enlarging this scenario, I think it is important, I mean, to highlight the fact that UV, either UVB or UVA, represent one of the most common or the most common treatment for early phase mycosis fungoides, and indeed are very, very active. Therefore, because a lot of times patients ask me, why, doctor, why don't you give me a systemic treatment? Okay, I can consider that. Sometimes also like retinoids in association with phototherapy, but in the majority of cases, phototherapy is highly effective and more effective than systemic treatment for early phases cases, and not for all the situations. So I think it's very important. This is originating and present in the skin, and skin-directed therapies like phototherapy are very, very effective. So it's important, and in the majority of cases also is associated with less severe side effects and toxicity with respect to systemic therapy. So it's important. I think that's an important point for the patient. And the second point, I think that is active, but sometimes relapses can develop during time, because mycosis fungoides is a chronic disease for long time, so for a lot of years. So some relapses can develop, or also there can be no complete clearance of lesions. So a few lesions can be present at the end, and patients don't be worried about that, because if there are a few lesions without itching, without significant, I mean, impact on quality of life, etc., there's no risk of having this lesion present and to follow this lesion without any additional treatment. So it's not the case to use, okay, for limited lesions, you can use topical steroids also, but no worries about the fact to leave some lesions which are stable without itching and without problems. There's no risk. So the point is, there's no risk for disease evolution to have some remaining lesions. So I think it's important. There's the aim, the objective is not to clear all the skin. Yeah, for sure, could be cleared, and we are more happy, and we try to do our best. But if some lesions remain, there's no problem. You can follow and wait and see what happens in the follow-up.
Thank you. I think that's a really good point. And if I can think back 30 years ago when I was first diagnosed, you know, when you get this diagnosis, you say, just eliminate it, right? It's a cancer, get rid of it, pull out the big guns, just get it out of my body. But really, the goal for this disease is use the least amount of treatment necessary for the shortest amount of time possible, but pay attention because it's chronic and it's over the long course of time. And to your point, we may not eliminate the disease entirely, but if you are able to live with it and you have a couple of patches and it's not impacting, you know, visibly, perhaps on your face or other areas, and it's not bothering you, as long as you're being seen and followed, that's okay. And not to worry that all of a sudden tomorrow you might wake up and have more advanced and challenging disease, because that doesn't really happen. It's not a quick thing. Thank you. Okay, I have another question here. I'm going to condense it a little bit to get to the crux of the question. It's someone who's asking on behalf of their mother, who was diagnosed with mycosis fungoides recently in March. And they did all of the tests, PET scans and tumor markers, and everything was negative. But she lost a lot of weight from March to July and changed her diet to be very healthy, and wondering, could the diet be the reason for the weight loss, or could there be a reason, is the disease causing the weight loss? And she's being treated with narrowband UVB, so it's kind of a nice follow-up to the question. So maybe a little bit around the impact of diet and how that might relate to the disease. And it sounds like they changed their diet to a very healthy diet. So, but substantial weight loss. So that's a little bit unusual. Anybody want to, Professor Vermeer, jump in here?
Yes, the fact that this patient is being treated with narrowband UVB suggests that we're dealing with a patient with mycosis fungoides with relative thin patches and plaques. So that would be early stages of disease. The fact that the PET-CT is negative is very encouraging. It means that the disease is only present in the skin and has not spread out to lymph nodes or other compartments. And combined, this means that we're dealing with an early stage disease that would typically not lead to weight loss. And I am inclined to think that the weight loss that this patient has might have to do with the healthy diet, and that in a way would be a good thing. My advice would be to keep track on the weight. If this should level out at a certain point and become stable. If it doesn't, that would be a good reason to talk to a physician again, because maybe something else is wrong. Could also be another reason for having weight loss apart from the mycosis fungoides. But based on the therapy and the negative PET-CT, I don't think the current mycosis fungoides would be the reason for this weight loss.
Great. Yeah. Professor Quaglino, anything to add?
Yeah, I think I agree. I don't have more comments. I agree completely to exclude mycosis fungoides as a cause of weight loss, and advise to perform perhaps some other blood exams or analysis to exclude other causes of for the weight loss.
Great. And maybe this takes us down another little pathway, but maybe you can share a little bit about your perspectives on nutrition. We get questions all the time. Should I change my diet? You know, there's a lot of, information out on the internet. Oh, cut out the sugar, cut out the carbohydrates. All these things cause cancer. Do either of you have thoughts and opinions on how diet may impact cutaneous lymphomas, and just giving folks maybe a little bit of a guideline in how to think about supporting their bodies and their immune systems right now that they've been diagnosed with cutaneous lymphoma?
Yeah, but I don't know if I can say, anyways, very rapid answer, in as much as I have to confirm that in my experience, I did not see any particular relationship between some diet situations and evolution or presence or disease evolution of cutaneous lymphoma. So in this case, I think that there's no particular point to discuss. However, it for sure is important to consider also food intake and correct diet. And I think that in the last years, particularly young patients ask a lot for a dietary consultation, and think that in some cases also in the multidisciplinary team, when asked for by the patient, is present also a specialist in nutrition and can give some advice as a general situation for a good dietary style and behavior, but generally not focused on cutaneous lymphoma. I think for general health condition of the body.
Professor Vermeer, anything to add?
I agree. We asked this question specifically to someone who was specialized in healthy lifestyle. And to make a long story short, there's not a specific advice that we can give to patients with cutaneous lymphoma. It's not like patients with cutaneous lymphoma should eat more apples or something like that. But in general, having a healthy lifestyle, and that includes no smoking, no alcohol or very limited alcohol, no drugs, having a very good diet, having enough exercise will make people more healthy, and that would help you because we know that in cutaneous lymphomas, it's the immune system plays a very important role in battling the disease, and in particular in early stages, keeping the disease under control. That would in itself be of tremendous help. Also, in more advanced stages, when patients are going through more intensive therapy, I think it's very, very important to keep patients healthy, and then having that healthy lifestyle, but then also paying attention that patients have enough calories to keep their body weight at least stable will be very, very important.
Good points. Follow a healthy diet, everybody, and get your exercise. Always a good thing. So noted. Thank you.
And the same advice is applied to the clinicians as well. So
that's right. You're not exempt.
A good point.
Oh,
Yeah,
that's a very good point.
There's an ancient Latin phrase which sounds like mens sana in corpore sano. So healthy mind in healthy body. And I think they apply for all the people. So then there are some exceptions for holidays or some celebration, birthday. I think we can say, okay, sometimes.
Right. Everything in moderation. Right. Okay. So let's may go down a different path. When should a patient? Not everybody has access to a multidisciplinary practice where you have experienced specialty dermatology and hematology, radiation oncology. When should a patient maybe move from a dermatologist to an oncologist? How do you determine who should be leading the clinical team based on the individual's patients? And I know it will vary a lot by country and accessibility to specialists and centers and geography. That is always a challenge, especially for a rare disease. People don't just get diagnosed that happen to live close to the specialty center, right? So if you have any thoughts or recommendations on how should patients think about who should lead their care, and maybe when you need to move into the direction where a hematologist becomes a little more involved?
That's a very good. It's a very good question, and you could say in a sort of ideal world, you would for every multidisciplinary consultation have all the relevant specialists that were just mentioned on board. If that's not possible, or if that's not practical, you could also say, well, if we could look at it a little bit different, and if we focus now on mycosis fungoides as an example, I think in the early stages of disease where we are dealing with patches and plaques, we need a dermatologist and we need a pathologist. Because the pathologist will tell me, is this indeed a case of mycosis fungoides, or am I dealing with an eczema or a psoriasis or something else? And you need a dermatologist to, well, as Peitro just described, make this distinction of giving UV therapy or giving local steroids, and have that discussion with a patient. At that point, we do not need a hematologist. So we would make good use of each other's time to organize in such a way that that I definitely discuss this patient with a pathologist, but I do not really need a hematologist at that point. If the patient progresses and would develop tumors, at that point, the radiation oncologist becomes a very good friend, and someone that we would really need and can really help us. And again, the pathologist will be important to tell me a little bit more about the histology of these tumors that develop, if there's plastic transformation, etc. Then, if patients get sicker and might have many tumors, or we are not sure if lymph nodes are involved, then at that point I definitely need a hematologist to combine or to be in that consultation with us. And then we typically try to organize combined consultations with a radiation oncologist and a hematologist. But we do not need the radiation oncologist and the hematologist to see every single patient. So it's with progression of disease that we need more input from the radiation oncologist and the hematologist. And I think, especially in the early stage of disease, it's the dermatologist that organizes the clinical care and organizes the specialties that specialists that are needed. At the point where people are being treated with chemotherapy, polychemotherapy, at least in the Netherlands, the hematologists typically take over, and they are the people that are in charge, so to say, of the treatment itself. But in evaluating treatment and evaluating the further therapy strategy, the whole team is involved again. But maybe it'll be good to listen to Peitro as well, because I know this is slightly differently organized in different countries.
Right.
Yeah. I agree. Basically, it's the same. I have to say that we have a multidisciplinary team in Turin, and first, I think it's important that the multidisciplinary team meets and define a common shared therapeutic and follow-up algorithm for the center from international guidelines, and also based on the availability of different drugs in different countries. For example, histone deacetylase inhibitors are not available in Europe and US, yes, so there are some differences on that. But I think that first it's important to have this group and to work together. I think that all the specialists define the therapeutic management in their center, and then agree that it's not. I mean, there's no need to meet and see all the patients independently from the disease and the stage. Dermatologists are more involved in early phase diagnosis with the pathologist, and for the treatment of early phases of mycosis fungoides, radiotherapies in the presence of disseminated plaques or tumors, and hematologists for chemotherapy, and then depends also on the specific availabilities in the centers and also organization, because for example in our center in Turin we perform chemo also in the dermatological clinic, and only in cases of bone marrow transplantation clearly patients are referred to the hematologist. So I agree with this situation, and I have to say also that in Turin also we have meeting with hematologists and radiotherapists also, apart from mycosis fungoides, also for Sézary syndrome patients, for the definition of the procedure and evaluation for bone marrow transplantation, and also in cases of rare cases of primary B-cell lymphomas. We did not talk about that, but there is a small part of cutaneous lymphoma, as you know, that are not of T-cell origin but B-cell origin, and the majority of these cases are very indolent disease course, topical steroids or localized radiotherapy, but there are a small part of this primary B-cell lymphoma, follicle center or large B-cell lymphoma type that can develop multiple lesions, and there's the important discussion about the treatment, radiotherapy or anti-CD20 or chemotherapy. So I think that also other diseases belonging to the spectrum of cutaneous lymphoma can be a good point for multidisciplinary discussion. So the point is, generally multidisciplinary, and the team need to work together. But for specific cases, patients in early patches, early phase mycosis fungoides, some patches, there's no need to sit all the team together. The decision is to move to phototherapy, UVB, and dermatologists can do that. It's important that the group share the same indication.
Right. Right. And
And the other, I think that I don't want to promote my talk, but I think it's also important. I don't know if also Maarten agree with that. Cutaneous lymphomas are a rare disease, and it's important to refer this patient to specialized centers because perhaps I don't know how to say in your countries, but in Italy, not all the hospitals have all the specialists and organizations to treat this patient. So it's not the case of being, I am better, I am not, it's not the problem. If there are specialized centers, we don't need a lot of specialized centers because are not so frequent these cases, but I think it is important the referral to these cases to some specialized centers that need to be identified by the national health system. And this is important also to give the patient the best treatment available, but also to collect data and to treat the patient homogeneously. Also in the case of clinical trials, to have patients for clinical trials is very, very important.
I agree.
After the treatment, the patient can be followed also, I mean, in other centers, but refer to specialized centers in the case of new treatment evaluation or problems or diagnosis of differential diagnosis. Excuse me, sorry.
No, I agree that this was precisely what I wanted to add. In particular, in the diagnostic phase, you could say every patient with a cutaneous lymphoma should be seen at least once in a specialized clinic. And I think that would be time well spent, because then you hear, okay, we know this, we have done all our tests, we've done the biopsies, we've done the blood analysis, we've done the immunohistochemical stainings, etc., etc. Now we know your diagnosis is this disease, and we know from this disease it will behave like this, such and such a thing. This is what we think is a good way to start the treatment now. And then the treatment itself, and maybe in some cases the evaluation of the treatment could be done in another center. We preferably like to see the patients ourselves, so we know if the advice that we have given, how well that worked. But if there could be circumstances when it's difficult for people to travel or for whatever reason, then we will ask our colleagues to take care of this patient, give a particular treatment. They can share pictures with us by mail or other means, and we can give advice from a distance. But we think that it's in the diagnostic phase very important to see patients at least once. And as Peitro already mentioned, there are a lot of different types of cutaneous lymphomas. So 4 or 5 different B-cell lymphomas, 15 types of or 17 types of cutaneous T-cell lymphomas. It's really a complicated field, and it's very important to have the correct diagnosis, have a good therapy advice, and then that advice itself could be done somewhere else. But then at least you know you're on the right track.
right, and actually that was my follow-up question, which you kind of alluded to, with regards to, I think, as a newly diagnosed patient, you don't always know what to ask, right? And I think it's so important to your point, if you have a diagnosis of cutaneous lymphoma, it could be one of many different iterations, and that specific diagnosis, whether it's mycosis fungoides or Sézary or one of the rarer of the rare, the cutaneous B-cell variants, or one of the other rarers or folliculotropic. I guess my question is, how important do you think it is from the patient's perspective to know specifically the name of their particular disease, cutaneous lymphoma, and the stage? And how does that fit into what you're both just talking about, the decision for treatment and what might be the best path forward? So how important do you think that is with regards to really knowing exactly what your diagnosis is beyond just cutaneous lymphoma and what stage?
I think it's very important. I think it's absolutely imperative that the moment we know what the diagnosis is in a patient. Let's say it's lymphomatoid papulosis. It means I have to discuss with the patient, explain the nature of the disease, explain how it works, and then patients will understand why we do not have to treat all the lesions all the time. And I think it's really important to, it's our job as clinicians to explain to people what disease they have and what it means to them. And also to help people understand a little bit what this disease, how important it is for you, what it can do, but also what it cannot do. And it will empower people to not be, how do you say, to be afraid of things that are not relevant to you. If you just say you have a CTCL, actually you do not know anything. You could have a CTCL from hell that would be very, very difficult to treat and has a very poor prognosis. Or it could be a disease that would be possible to treat with a local steroid, and we do not have to be afraid of any complications. And it will be very important, and I think absolutely central in our job to give the right information to people there.
Great.
Yeah, I completely agree. And just a short comment is not easy. It's not easy for the patient because this is developing the skin so highly visible, and also to understand the fact that this is a tumor, but in the majority of cases the disease evolution is indolent. So it's really important, because I see a lot of patients at first diagnosis of, for example, mycosis fungoides, because it's more frequent. And if you check in internet, it's also the majority of cases see very bad situations that rarely occur. So I think it's important to share the fact that even if it's a lymphoma, is different the majority of cases from lymphomas, of nodal lymphomas, and only a minority of patients, unfortunately, for these patients develop advanced disease. So it's difficult to give the balanced information. This is not psoriasis. This is not an inflammatory disease. This is not a mycosis also, because sometimes it happens that some people ask me, is a mycosis, is infectious disease. No, the name is like that. Anyway, I have to say that into brackets also some clinicians sometimes ask me, why do I have to give an antimycotic treatment for this patient? No, it's not the case. Also clinicians, I have to say. I don't know if in your country happens this, Maarten, sometimes rarely in Italy this happens. Anyway, I think it's important to give balanced information. Sometimes, I mean, you have to, for sure, I am sure that I will see this patient sometimes during the next weeks or months. So it takes some more than one visit. So it's not the case. I think the first visit to say 1, 2, 3, 4, 5, at the stop. Say, I mean, at the first visit, I say 1 and 2 and say something, and then next visit, perhaps the patient asks me something. So I think it's important also to follow the patient and leave the patient consider that and make some questions so I can answer and understand better what the patient, which are the patient problem, and how he or she understood the situation. But it's very difficult to do that. And I have to say that also in recent years, sometimes it was important to get the help of a psychologist. We have in our multidisciplinary team for skin tumors also some psychologists specialized in neoplastic pain, following and take care of neoplastic patients. Sometimes could be useful. I mean, in the past, when I suggested patients to be followed by a psychologist, in the majority of cases they say to me, I am not mad, I don't have psychiatric disease. Okay, but it's different. Now I think that in Italy this has changed, and also patients are happy to have this help. But I mean, not for all the cases, also specific cases could be also a possibility.
Yeah, I think that's great, and thank you for that. And I'll just put a little plug in for us, the Cutaneous Lymphoma Foundation, because I think to your point, you can't absorb all of this information in one sitting. It takes time, and it's very complicated disease and how it fits, and it's different than what maybe most people are aware of with the more common types of cancer, breast cancer, prostate cancer, and so forth. It's very different. It's treated differently. It's just a very different animal, if you will, and it takes time to absorb that. And that's kind of why we can play a role too, and try to share and help people get information in small chunks that can be digestible and understandable, and then formulate those questions to come back to their clinicians and say, okay, this is what I think I understand. Where do I fit? And how do we work together to treat my particular iteration of this disease? So it's very important. All right, so I have some interesting questions here. So we have a question from a patient in Germany who was not diagnosed early. She was diagnosed with eczema and so forth. It took 7 years for her to get a correct diagnosis. Not unusual, sadly. But she's had 4 children, and seems to have an iron deficiency, which is causing her to feel tired. But there's some discussion with her GP and her clinicians that perhaps being on birth control pills targeted her mycosis fungoides. And I'm guessing there's not been any data around that. I don't know that we've captured any of that, but have either of you any thoughts on any connection with birth control on triggering mycosis fungoides, or any correlation? Because it's now, they're looking at treating her iron deficiency and going back on birth control. And is that going to exacerbate or have an impact on her mycosis fungoides? So it's an odd duck, but we get interesting questions. So thank you for that question.
Yeah.
Any thoughts?
Very simple answer from me would be no. I've never seen it. I've never heard about it, and I don't think there's any danger in having birth control, anticonceptics, pills. So we have never seen an acceleration of disease course, and we do not see. We also see MF in men, and it's typically a disease of somewhat more elderly people, not old, but more like in between their 50s and 60s. So I don't think there are strong arguments that there is a connection with any hormonal compartment or influence. Sorry.
Yeah. Me too. The same. Unfortunately, we know that in some cases there can be a relapse of the disease, and also some patients can develop advanced phase disease. But unfortunately, we don't know which would be the factors related to that. Probably there are some differences. We have some recent data about molecular expression of specific mutations, so some kind of related to the tumor or whatever. But we can exclude this, or rather a situation from outside that can induce a relapse of the disease. I would also take the occasion of the story of this lady to highlight, I think, the fact that in the majority of cases the diagnosis is delayed. There is a long time to get the diagnosis because it could be difficult and take some time, because at the beginning the disease can have very mild lesion, very difficult to diagnose. And indeed, as you know, in the recent registry that we have, ProClipI worldwide, the median time from the onset of lesions and diagnosis was 3 years worldwide. but this is not a problem. So this delay is not related to a higher risk of having aggressive disease or whatever, because this is a very indolent disease. So I think that the good message for all the people is don't be worried if in your personal clinical history there's been a delay in the diagnosis. I mean, for sure, in an ideal situation, we all agree that it's better to make early diagnosis. I think there's no discussion about that. But don't worry about the delay of the diagnosis. I think the only point is in some cases where diagnosis of psoriasis or eczema, which are more frequent, was associated with a treatment with immune suppressive drugs, or this could be a challenge because immune suppression, we know that it's not good for cutaneous lymphoma. So I think this is more for clinicians. So when you treat a patient with psoriasis or eczema, with particularly psoriasis, with this immune suppressive treatments, anti-TNF, etc., be sure that this is a psoriasis and not other, for example, rare cases of lymphoma. But outside these very rare cases, the general, I mean, message to give, don't be worried about the fact that in your personal history, the disease diagnosis was made after some months or years after the beginning of lesions.
Right. Yeah. And I think that's really a good point. The disease itself, as you mentioned, is very challenging to diagnose, especially
always
at
mycosis
stage,
fungoides.
right?
Excuse me, Susan, sorry. Always mycosis fungoides. Other cutaneous lymphoma cases, very rare and aggressive, is different story. I was talking generally about mycosis fungoides.
Right. Right. Yeah. Yeah. Okay. So let's see. We've got a couple minutes left. I want to toss out one more question, which you sort of answered and alluded to, but when you're talking about light therapy, we talked about that a little bit in depth, but perhaps the person didn't quite hear. How long can you do light therapy? You know, you talked a little bit about, you know, maybe you do 3 or 4 months and then you stop and take a break. You go back. Can you do that for ever? Is there a point when you say you've had too much, or is there a difference maybe with the different types of light where you might have, if you're talking UVA light, since it penetrates a little differently, maybe there's a little different threshold for that for lifelong use?
There are guidelines. We have guidelines for the maximum number of cumulative UV that we are allowed to give to patients. But these guidelines have been made for patients that have eczema or psoriasis. So my argument would always be that I'm treating a very difficult disease. If I would not use light therapy anymore, I would immediately have a problem. What would be the alternative? And we try to not get into that sort of problematic situation by trying to rotate our therapies in a clever way. So we try to use light therapy in those patients that have extensive patches and plaques, try to combine it maybe with interferon or with local steroids, or maybe vitamin E derivatives to tablets to make that light therapy more potent, and in that way limit the amount of UV exposure that you give to a patient. So we're always trying to think long term. We're not only thinking about the treatment of today, but we are also thinking about the treatment 10 years from now. And so then sometimes we have to accept that a little bit of the disease will be there. We will not be able to get rid of everything. But if you do that, and that's where I would say the experience as a clinician comes in. but also the communication that you have with your patient, and that together you should make that sort of long-term treatment plan. And you could say something like, I'm going to treat you for 3 months. Let's see if we can do this treatment for 3 months or 4 months. Then will be April, and you will go outside and get a little bit of natural light. Be careful not to get too much sunburn, because in a way, light therapy would be a sort of more uncontrolled UV exposure. But then we'll try to switch to local treatments, local ointments, and if that works for you, we could, you know, see if we can not use light therapy for a year or longer. And another sort of rule of thumb that we try to use is limit the number of courses of light therapy that we give to patients to 1 every 1.5 years, so to say. And if you do it in that way, and we now have quite some experience with that, we can really treat patients for a very long time using that therapy.
We have one last question that came in, and I know we only have a couple minutes, so this is a good one. Someone was asking about what are the tests to monitor the disease and assess the disease, and what makes it possible to check for blood involvement. So how do you determine if someone has blood involvement? And what?
Well, that's a project that Peitro and I together are working on. So that's
you are the leader. You are the leader of this project. I'm following you, definitely. That's the project. Thanks for the.
But thank you. It's an excellent question. I'll try to answer it as short as possible. It's a difficult one to answer. The point is, in early stage disease with patches and plaques, if you do normal routine blood assessment, you will not see any signs of circulating tumor cells. But we know they're there because the tumor cells probably do not crawl through the skin from one side of your body to the other side. So there has to be a sort of blood phase where the tumor cells travel. With much more advanced disease, when patients are erythrodermic, and then you can, with this normal therapy, normal assessments that we use now, the normal flow cytometry, we can detect circulating tumor cells. But we now are developing a much more sensitive flow cytometry platform, and we've already used it in advanced disease, and we can see that we can detect and quantify tumor cells much better than we used to. And we're building on experiences from others, of course. A lot of experience come from Turin, from the lab where Peitro is working. And in particular, the loss of CD26, for instance, was described in his lab for the first time. But we are now combining it with novel markers and using new software. And in a way, I'm very happy and very proud that we have brought together 17 different centers in Europe that are now collaborating using this new flow cytometry platform to detect and quantify tumor cells in advanced stage disease. But the next thing we will do is also do it for less advanced stages of disease. And we're very curious what we will see. And maybe it can help us to identify those patients that are at risk for progression.
That's exciting. So let's see, we have another minute. Professor Quaglino, anything that you want to jump in our final minute of discussion?
I don't know, just to follow the question of the patient, and I think that generally, because it's a frequent question from our patient, there's no specific marker in the blood that can be routinely used to monitor the skin disease. I mean, the skin disease is visible, and I can check the skin and see how is the disease, but there's no marker in the blood that can be followed to identify if the disease is worsening or improving in the skin. It's only the clinical picture. Okay, what Professor Maarten was mentioning is another point, is the involvement of the blood by the disease, and that's okay. But there's no specific marker in the blood to be related with the diagnosis of mycosis fungoides or the evolution in the skin of the disease. It's not like other tumor. There are some cancer markers. There's no availability of this marker now.
Mm-hmm. So
Only
look at the skin, right?
Yeah, yeah.
Mm-hmm. Wow. Wow. So we could probably ask a lot more questions, but we're at the top of the hour. So I will say thank you very much to both of you. And I know you just came off a very busy week and being at a conference, and appreciate your time on a Saturday to answer some of these questions and share your wisdom and your knowledge. And again, we really deeply appreciate your time and effort and the presentations that you did for us in both Dutch and Italian. It was very wonderful, and we'll have those available for patients as well to watch after our program today. So thank you both very much. I wish you a very wonderful weekend and a restful weekend with your families. And I'll actually see you both in Madrid in another week or two.
Yes.
Okay. Looking
Many,
forward.
many thanks.
All right.
Thank
Many
you.
thanks. Take good care.
Thank you. Take care. Bye-bye. Thank
Bye-bye.
you so much.
Bye-bye. Thank you.
Bye.